Thank you. Hi, everyone. My name is Candice Ward. I am Cat and Diab's Training and Outreach Manager. I am a clinician by background. I have worked in type 1 diabetes and technology for many decades, but had the privilege of being part of Cambridge University Hospitals, which is where Roman Hovorka developed the algorithm. And we have been working with him to sort of via the research and also to promote it widely. So we are here just to share our clinical experience in how to use this system in real world life. So happy to be here and looking forward to your questions. Clina, do you want to introduce yourself?
Yes, thank you. Hello, everyone. My name is Clina Miles. I'm originally from Ireland, but now I live and work with Ypsomed in Switzerland. I started last year in the scientific affairs team here. And before that, I also worked in Cambridge as a diabetes educator. So delighted to be here, and hopefully we can give you some tips and tricks for this age group, and also looking forward to your questions. I think you're on mute, Helena.
Yeah. Okay. Sorry. Next slide. Yeah. Okay. So I mentioned that iOS launched in Nordics last week, and we're very excited. And we know that a lot of people have been waiting for this, both healthcare personnel, but also patients, of course. So we are just very proud that we are connected to iOS and Android, and also the choice of Dexcom G6 or Libre 3 Plus or Libre 3. So it just makes it a very well-rounded system and very flexible for the patients. And we're very, very happy that this update came. And so it's been a week. Next slide, please. And we have thousands of patients that already have made the switch. And we can see in the Nordics that they have been super eager. So we have twice as many percentage-wise in the Nordics that has been switching as the rest of the world. So it's very exciting. And these are just two of the patients that have been switching, and they just their testament is just that it's been very easy and very smooth just to switch over. And I have linked those QR codes here to your fact sheets of your country, so you can scan, and those are on our website actually, so you can just help your patients switch and also share this.
And don't forget, the app has a virtual mode. So if you want to download the app onto your phone and put it into virtual mode so that you have something like a simulator, just to remind yourself where those features are, what those features include, and how to use them, they are available, and you can use your Android or iOS phone. So do download the app for yourself, have it on your phone, and put it into virtual mode so that you have that just support when you see your users using the system.
That's a great point. Thank you, Candice. Okay, next slide, please. Okay, so I'll hand over to you.
Thank you, Helena, for the introduction. So I'm going to start off the session, and then I'll hand over to Candice a little bit later to go through some more examples. So what we're going to cover today is type 1 in teenagers and young adults. The research that CAM-APS-FX has been involved in this age group, we're going to briefly mention that. We're going to go through the customizable features, which could be helpful for this age group, and then some tips for using it in challenging situations such as exams, with hormones, alcohol, exercise, and meal management. If you have any questions, please pop them in the questions box down the bottom. So you'll see that there's an icon for questions. If you pop it in there, then we can answer them as we're going through. So straight into it then, teenagers and young adults. Why are we having a webinar dedicated to them today? So we know that their brains work differently to adult brains, and because of that, we should support them a bit differently. So this is a really influential time for them. They're developing their personalities and their brains through social experiences and their peers. We know that they don't have the stress response like adults do, and actually they don't have those coping mechanisms or coping strategies like adults would. And it's where some mental health illnesses can develop as well at this age group. So it is a period of time that is particularly difficult for diabetes treatment. It's a difficult time anyways, but then with a chronic illness on top of it, it's really tricky. On top of that, there's lots of physical changes happening in the body, which can make diabetes very unpredictable as well. So it can just be a really tricky time for them. So we do need to support them. So we have maybe a solution that can help with that. So with mylife Loop, there is some very customizable features that maybe can help with this age group. So we are going to go through a few of those today. To just name a few, there is the 2 sensors which can link to it, and now there's the 2 types of phone as well. So that can make it just a little bit more flexible for maybe patients who have that are on either of those sensors, or they might be a real Apple user, at least now that they can utilize it on the phone that they like to use. Quickly, just to show you, there is a lot of evidence using CAM-APS FX in this age group. So there's been some studies that looks at the safety and efficacy, but also some studies that look at using it straight after diagnosis, using it more in a fully closed loop way. And it really shows that it can be very successful in this age group. So some of these personalized and flexible features then, so we're going to kind of focus on 4 main ones, and I'm just going to briefly show you where these are in the app in case anyone isn't familiar with where they are. So I'm going to just briefly show the personal glucose target and how it works, boost, ease off, and add meal. So first of all, going through personal glucose target. So this is where the algorithm is going to work really hard to keep the blood glucose or the glucose levels at. So it's going to try very, very hard to keep it at that level. So you can put it anywhere between 4.4 and 11 millimoles, which is really good that it caters for both ends of the spectrum. So if you do have those maybe non-compliant teenagers in clinic at the moment where you'd like to offer them an AID system, but they can't run as low as something like 6 or 5, you could offer them this system, put a higher glucose level, and then really fine-tune it and drop it gradually. So it does offer a solution for those sort of patients as well. And then also you can have a very tight level, a very lower level if you want as well, because it goes as low as 4.4. So if you have those teenagers who are particularly struggling with things like hormones and things like that, and they might need more insulin, then you can be a bit more aggressive and put that target down. So it does allow really good personalization. You can put it in 30-minute intervals, so it can be 48 time blocks throughout the day and night. So it just means that if you're noticing their insulin requirements change very differently throughout the day, night, morning, evening, you can really utilize those time blocks as well. The default is 5.8, but once you toggle it on, so you can see that it's here in the main menu under settings. Once you toggle it on, you can customize it there to what will suit that patient. So moving on then to Boost. So Boost is a option where it can intensify the algorithm a little bit more. So not really no other system has this option. So it can be really helpful during the teenage years. As I mentioned, particularly in things like hormones or situations where maybe there's more, they're a bit more anxious and things like that. Boost can be really helpful for those scenarios. So you can see here, it can be put on really easily. So in the front screen, there's a button straight in front of you, which has Boost. When you tap that, it'll ask you how long for. You can run it for a max up to 13 hours, and you can pre-plan it as well. So if you're kind of expecting maybe levels to be running higher for any reason, you can pre-program it to come on sometime that day. Events that can be really helpful for is kind of low-grade illness where there's no ketones, so coughs and head colds and things like that, stress and pain, any sort of hormonal PMT that maybe elevated hormones can be really helpful for that period of time. If they're using other medications like steroids, or if they do miss a bolus or they have some infusion set failure, boost can be a really safe option to use instead of having to correct and they don't know how much to correct by, etc. This can be really helpful for teenagers because they can just pop on boost and it's safe because it'll only give more insulin if they need it. So yeah, really helpful feature there. Then we have the other side of the coin. So we have ease off. So this helps reduce the insulin delivery if needed. So can be really helpful in things like exercise or hot weather, or maybe again, if hormones reduce, like the day the period starts, or if there's any sort of maybe events that they have coming up where they're more active and they're running lower, you can pop on ease off for those things. So again, a really easy feature. It's on the main menu. You just pop it on and it can be run up to 24 hours at a time. And it can also be pre-programmed. So say you know that there's going to be a particularly active evening, you can program ease off to come on early on in the day if you want to run a bit higher for preparation in that evening. So again, a really nice, easy feature to use that might be helpful for some of your teenagers. And then the last feature I'm just going to mention is Add Meal. So Add Meal offers more bolusing options with the mylife loop. So basically, it offers different ways to bolus for different types of meals. So for example, we have one that is called slow absorbed meal. So that is, you know, those tricky meals like lasagna or pizza where there's a lot of carbohydrate, there's a lot of fat and protein as well, where you might notice you need to advise somebody to use this is if initially they have a hypo and then later on they're climbing really high. Actually, this can be a great option to use. Under Add Meal, there's also the hypoglycemia treatment. So this is just that they can notify the app that they've treated a hypo, which is a great habit to get into because then you can see that they've treated it with a certain amount of carbohydrates. So I find it a really helpful thing, even reading downloads that I can see that they have treated their hypo, but also it notifies the algorithm that we've treated a hypo. So, you know, it might know to back off for that period of time. And then there's also a meal and snack option. If they're going to have maybe more snacks, but they're not sure if they need to bolus for it, they can type it in here. So some really nice options there for this age group where we know they snack a lot. We know that they eat maybe a lot of these high carb, high fat meals. So you can really nicely use those features. For the slow absorbed meal, it is important that you advise them to split the dose. So to give initially some insulin up front, like maybe 40 or up to 60%, and then the rest can be put into the slow absorbed meal. And you can see that this is accessed directly in the main menu, and it has its own toggle of main meal there. So now that we have gone through those sort of main features that can be helpful to this age group, I'm just going to go through some of the challenging situations, and I'm going to hand over to Candice during this as well. So the first thing we're going to talk about is exams. So we know that this can be a particularly very stressful period for this age group, and notoriously this age group get a lot of exams throughout their teenage years. So really tricky to manage with type 1 diabetes. And we also want them to perform at their best. So we want their glucose level to be optimal as possible. It is important that the young people feel supported by their schools and universities with their type 1 diabetes. So always really important that they have their equipment available and that there is some sort of discussion had with the school and university that they can support the young person to always have the equipment available in a safe way. Access to their phone is quite important when they're using CamAPS. Obviously, all the alarms are on the phone, the glucose levels, the arrow, how they control the algorithm is on the phone. So really important that that is also discussed and agreed with the university or the school. Hypo treatments and snacks should be within reach. And also, they may need more rest breaks. So it is important to note that after treating a hypo, it can take up to 45 minutes before the glucose is back into the optimal range. And really before then, it's not fair to expect a young person to perform their best in an exam. So having the school and the universities understand this is really important for the young person. So how can mylife Loop help in this scenario? So we know that most teenagers struggle with higher glucose levels during exams. Now, there is always the exception and everyone's different, but mainly we see that these exams cause a lot of anxiety, there's a lot of adrenaline, so we do notice that there is some insulin resistance and they often run a bit higher. So because of this, the features that may be helpful is things like Boost. So as we mentioned earlier with Boost, it does intensify the algorithm. It lets the algorithm give a little bit more insulin if it needs to. So this can be a really safe option that the teenager can pop on, and they don't have to worry through their exam then, because they know that Boost is safe. If they start to their blood glucose starts to drop, it will cut out and it will reduce the insulin delivery as well. So it is a really safe option. As we mentioned, it can be run up to 13 hours, 12 hours and 59 minutes. So if you have exams that are a long, maybe a few hours long, this can be a great option. However, we could also utilize that personal glucose target, because we know that exams usually don't come in ones. They usually are like a whole week of exams, or maybe there's a long period of time. So they could utilize that personal glucose target to maybe be a little bit lower. So they know that the algorithm will be able to give them just that little bit more insulin. So yes, it could be a great option. We also know that while they're studying, maybe they're less active, so they might be sitting for long periods of time. So utilizing the personal glucose target for that period of time, the exam period, might be a good idea. But it is important that they know to put it back up again, because you don't want them having hypos then when they start living their life again and they're more active again. So they're just two ways that maybe mylife Loop can help in exams. I'm going to hand over to Candice now, and she's going to go over hormones.
Thank you very much, Clina. So just like exams or any stress, the usual menstrual cycle can influence what's happening in a woman's sort of insulin resistance. And so it is important to support young women being able to identify periods of more insulin resistance versus less insulin resistance as we're going along. And we do know that in the luteal phase, or the second half of the cycle, that with more progesterone, people are tending to have more insulin resistance. There tends to be more food craving, more sort of people are tending to eat potentially more in this time period, and so it does lead to more higher glucose levels versus when the period starts and estrogen starts taking over, where we often have lower glucose levels. Everyone is different, so it's really hard to say a day this do this and a day that in the cycle do that. But certainly, again, I find a lot of women find it useful to potentially use Boost and run it for 2 or 3 days before their period, if that's where they know there's a lot more significant higher glucose levels than usual. And again, as Kleena said, it's safe to run. It also is useful to proactively run it in situations where you have transiently changes in insulin sensitivity, so like sickness, exams, or things like that, because it actually protects the original learning from the algorithm. So if the algorithm is seeing that insulin resistance is happening, it'll become more and more and more aggressive because it's learning that this person is maybe growing or something's happening that is a permanent change. If it's a temporary change, like a couple of days in a menstrual cycle or illness or a stress, the algorithm shouldn't be learning about it because it's going to disappear soon. And so using Boost actually protects some of the learning that helps when the person goes back to being normal again, as it were, the algorithm isn't too aggressive. So use Boost proactively during these periods. Some women who have sort of more severe insulin resistance in this PMT period may need to adjust their insulin to carb ratio, or some people leave the ratio but then add a percentage more onto each bolus that they deliver because they know they're more resistant to carbohydrate in this sort of small window, and need to give more insulin. The one useful thing that people often don't remember is on the day the period starts, there's suddenly a shift in insulin sensitivity. And so some women really struggle with recurrent hypoglycemia, going from using a lot of insulin to the day or the first 24, 48 hours after the period starts. And so sometimes women find it useful to then run ease off for a 24-hour or 48-hour period, just to help with that sudden shift in insulin requirements and differences. So do think about those two features to utilize as part of the menstrual cycle as well if you've got young women who are struggling. Okay. There is a question, I might just handle it now. There's a question around Boost, increasing the doses. Does it take every 8 to 12 minutes a new assessment into account, and what happens? Let me just describe this quickly, and I can always come back to that question if I haven't answered it fully. So when Boost is running, the algorithm is still using its learning that it's got on board at this time, and it's still using the target that you've asked it to aim for, still forecasting ahead every 2.5 to 4 hours. So it's using all the same, but while it's crunching its numbers, as it were, every 8 to 12 minutes, it has 8 different potential calculations that it can utilize at each different time. It can actually even combine some of the calculations together. And each one of these 8 different parameters have a different sort of input, a different sensitivity factor, a different pharmacokinetic and pharmacodynamic influence that helps, it understands some are weaker and some are stronger. And so when you're using Boost, you're saying to it, please use some of your more insulin sort of resistant, more aggressive calculations, still using your learning, still using the targets and the outcomes, and still reassessing. So if it was more aggressive in an 8 to 12 minute cycle and then glucose levels were, started to drop, it would go back to being less aggressive in that period, but you are asking it to be more proactive. Ease off would be the opposite. It's asking it to be less proactive. Remembering ease off is also raising the target and will shut down insulin delivery at a higher level besides how it crunches its numbers. So hopefully that helps you sort of understand how Boost is doing that sort of calculation as an extra layer on top of how the algorithm is normally working. Right, next slide, please. Okay, so alcohol is something, as many of our young adults are consuming. They're enjoying out, partying with their friends. Often comes together with exercise. So somebody's on holiday, or they're doing a sports event and then going out and celebrating afterwards. So the worrying thing about hyperglycemia, about alcohol, is certainly the hyperglycemia element, that people, when they are sort of intoxicated or drunk, it comes across as maybe being hyperglycemic, and because they've got a drink in their hand, nobody's thinking about the type 1 diabetes and the hypo, they're thinking about the alcohol. So certainly we'd like our young adults to drink alcohol, responsibly, have somebody with them that knows they've got type 1, and so if they are acting strangely, checks with them that it might be their glucose, not the alcohol, and then just making sure that people are aware of what alcohol does. Depending on what people are consuming will have an immediate response to their glucose levels. They're drinking something like beer or cider or an alcohol mixed with Coke or something with sugar, glucose levels generally rise, compared to sort of wine or pure spirits that have no carbohydrate. But what the big problem we wanting to keep our users safe is what happens delayed. Most people will have a delayed effect. If we swap over to the next screen, please, Cleaner. The delayed effect of the alcohol is a real worry, where the liver is not boosting glucose levels overnight, and you see that slow drift down to what we sometimes see in the wider type 1 area is severe hypoglycemia between sort of 2 and 10 a.m. the next morning, without the glycogen response, because the liver is busy detoxifying alcohol, and which makes the severe hypoglycemia worse. And so in alcohol, I, as a clinician, am not too worried about a little bit of high glucose levels while they're out and drinking. I am really worried about the repercussions and later things at night. So, to try keep people safe when it gets, I call, very messy, when people have had too much to drink. A little bit of alcohol, is easy to manage, and you may want to, if somebody is just having that one beer and they're at the pub and they notice their glucose levels, they may, just leave the alcohol algorithm to top that up, or may want to give a little bit of carbohydrate for that beer. But when people are drinking a lot more, as well as being physically active, we would not recommend, giving any insulin for that, just because of that potential worry later on. Certainly, there's some normal guidelines that we've been using for years around type 1 diabetes and trying to get people to not drink too much, not drink on an empty stomach, sort of alternate their alcoholic drinks with non-alcoholic drinks, just to reduce the amount of alcohol on board, would still be, good sense in this point of view. But on the next slide, we'll show you sort of what can CAM APS, what can we do there. So certainly, I think the algorithm, all hybrid closed loop algorithms, will mop up extra snacks and things that are consumed, but we don't want people to actively add extra carbohydrate as a bedtime snack like we might on pump therapy, because that will just increase the insulin on board if people are eating a lot of food before bed. To try pop up glucose levels, the algorithm is going to respond to that rising glucose levels and bring glucose levels down. To keep people safe from that delayed hypoglycemia overnight, we would use ease off. Ease off has that functionality that you can program it in advance. So we're not asking people to, when they come home after a night that they've consumed alcohol, that they're engaging with the app in a way that they might make mistakes and harm themselves if they are under the influence. We would want them to program ease off before they head out. So you can set ease off up to 24 hours in advance. And so I normally say to people, when you getting dressed for your night out, you're doing your makeup and brushing your hair, just set ease off to kick in maybe at midnight and run it for the next 12 hours so that it can keep you safe. It can just ask the algorithm to be more cautious for its learning, shut down at a higher level and aim for a slightly higher target over that period of time, just to keep you safe from that severe hypoglycemia. If people do want to add their meals, they can use add meal. But again, I don't really want people to be, interacting with the app when they're intoxicated. So it's just really that ease off is the key message, is the minimum. If you're going to only do one thing to keep yourself safe while you're out, it's ease off. Thanks. Next slide. Okay, so type 1 diabetes and exercise. As you're well familiar, exercise is really complex and it is really individual. The person, what exercise they're doing, what time of day, all of these things all play into how people are going to respond. And so what we're trying to convey is what are the tools have you got? So to manage your glucose level, this exercise may push up or push down, but I can control my insulin delivery, I can control the carbohydrate, and I need to know what this exercise is doing to be able to count those three together. And a group, the EASD and ISPAD, led by Othmar Moser, came up with a guideline. You may have already seen. If you haven't seen it, please just Google it. Covering all AID systems and what are the levers you can utilize. And out of that, we developed an animation using Othmar and a few of his colleagues, Clement, to try convey in a very easy way what tools have you got. We are busy translating this into a number of languages. It's in English at the moment, so we'd like to show this to you. This is what people will have in their social media and in the in-app training as a way of just going through the levers for CAM-APS. So next slide, please, Cleaner. Sorry, you're on mute, so we can't hear it.
We've spent years researching the effect physical activity and exercise has on people living with type 1 diabetes.
We know that being active is good for our mental and physical health. However, many people with type 1 worry about the impact activity will have on their glucose levels, preventing them from enjoying sport and exercise.
It may feel like a constant juggling act to keep glucose levels from going too high or too low. There are a few things that people might like to take into account to help them manage exercise. The type of activity that is being done, as well as the intensity and duration. Aerobic activity, like walking, running, cycling, and swimming, is often done over a prolonged period of time and generally causes glucose levels to drop. Mixed activities, like tennis, football, rugby, and basketball, which combines prolonged aerobic activity with bursts of high-intensity activity, generally keeps glucose levels more stable during the event. High-intensity, anaerobic activity, like weightlifting, karate, and sprinting, are generally explosive and short in duration, can cause glucose levels to rise. Competitive sport or matches can also cause glucose to rise compared to training sessions due to the excitement and stress of the event. It is important to note that everyone is unique. Some people's glucose levels might respond to the same activities in a completely different way to others. The amount of active insulin in the body, or insulin on board, will also influence glucose levels. The higher the amount, the more risk of having a low glucose level, or hypo, while exercising, because the body is more sensitive to insulin when active. It is important to think about when last you gave yourself a bolus of insulin, as well as how much insulin the algorithm has also been giving. If your glucose level is dropping before starting the activity, you are also at a higher risk of having a hypo during the event. The time of day you are being active can also affect how glucose levels respond to the activity. Some people might be more insulin resistant in the mornings than later in the day. There are many other factors that influence glucose levels, even when doing the same sort of activity. For example, your overall fitness level. The fitter you are, the less the activity might impact on glucose levels. When last you exercised, are you rested and your muscle energy supplies restored? Hormones and stress levels. A woman's menstrual cycle will influence her insulin sensitivity at different times of the month. Diet and body shape. What someone has eaten that day, as well as their body's fat and muscle composition, will also influence how they respond to the activity.
Now that you have considered all these things, you are ready to think through what adjustments you need to make to keep glucose levels stable during and after the activity you are about to do. If the activity is planned, you are able to prepare ahead of time and adjust your insulin dose or the app settings before starting the activity. However, if the activity is unplanned or spontaneous, you won't be able to change the amount of active insulin in your body, so we'll have to make other adjustments. For planned activity that could cause your glucose levels to drop, you can think about the following options. 1. Reducing the insulin bolus for meals and snacks eaten within 1 to 2 hours off the activity. You might also need to reduce the bolus if eating while active, such as when doing an all-day hike. Meals or snacks eaten directly after the exercise might also need less insulin than usual. 2. Setting ease off to start at least 1 hour before the activity. You should continue to use ease off during and after the event, if necessary. While ease off is running, the algorithm is more cautious. It aims for a slightly higher glucose target and delivers less insulin to try prevent hypos. 3. If ease off is not enough, you can also temporarily raise the personal glucose target in the settings menu of the app. This is the target glucose the algorithm is aiming to achieve. But please don't forget to put it back down afterwards. For planned activity that is expected to increase your glucose levels, you can think about 1. Starting boost when you begin the activity. While boost is running, the algorithm will be more responsive to high glucose levels, but will still stop insulin delivery if glucose levels are dropping. 2. You can also temporarily lower the personal glucose target, if appropriate. 3. Programming ease off after the event, if delayed hypos are an issue. For unplanned activity, you can consider 1. Immediately starting ease off, if glucose levels are expected to drop. 2. You can also increase the personal glucose target, if appropriate. 3. Eating or drinking extra carbohydrate. The amount needed will depend on the active insulin on board, glucose trends, as well as the activity and its duration. It is worth taking small amounts of carbohydrate at a time, between 3 to 20 grams, depending on your current glucose level and overall glucose trends. You will need a larger amount of carbohydrate if your glucose levels are dropping fast and a smaller amount if they are dropping more slowly. If practical, you can enter any extra carbohydrates consumed in ad meal under hyperglycemia treatment. It's important to try keep a note of what exercise strategies you have used and how well they worked. It will help you learn more about how your body responds to the different activities you do.
Please seek support from your diabetes team for further individualized exercise advice. That's all from us for now. Goodbye, and don't forget to have fun being active.
Thanks. Next slide. There was a question around ad meal and when to enter it for exercise. So in that animation, we recommend that exercise carbs that are used to boost glucose levels or because of the activity are put into ad meal and under hypo treatment. Why? Ad meal itself is an announcement to the algorithm to do something with these carbohydrates. So the algorithm has an understanding every time it's crunching its numbers every 8 to 12 minutes of how much insulin's on board, how much carbohydrate is on board, and glucose trends. And so when you put in ad meal, you're telling the algorithm, I've had 5 grams of carbs, but what should it do with it? Meal or snack is saying 5 grams of carbs. I've, as a user, chosen not to bolus for it via the bolus calculator. But if my glucose levels rise, that might be and cover it. The hypo treatment tells the algorithm, hands off these carbs. These carbs are to either rescue me from being too low, or they're used to top me up like in exercise. And I actually am not sitting having 5 grams, just a piece of fruit, doing work. I'm having 5 grams and I'm being physically active. So it doesn't cover the carbs when you announce hypo treatment in the same way as it would for meal or snack. And so that's why we encourage in exercise that if people are drizzling in carbs to boost glucose levels, the algorithm shouldn't be routinely covering it as a snack if you're having a picnic sitting under a tree. Okay, so we're going to talk about bolus. Yeah.
Here, so you added into the hypoglycemia bit, not the meal or snack bit.
Yeah.
Yeah.
For exercise associated carbs. This is not just normal snacking. I've finished my exercise. This is part of that drizzling in effect that we recommend when people are carb supplementing. So some people prefer to run their insulin and eat more to top up their glucose. So if you're doing that strategy, add meal and hypo treatment is the one we would recommend to help the algorithm make the right decisions. Okay, so with bolusing, I think especially in the young adult population, we are, they don't want to be different. They want to be just like their peers. And so the ability to be able to engage with their diabetes via their personal phone is really powerful. And that's one of the things when we do user surveys, the discretion, to be able to interact is really positive. On the next slide, you'll see this is just from our research, because we have designed an algorithm that is very sophisticated but packaged in a very easy to access sort of app that tries to reduce the amount of interaction and the amount of burden of managing diabetes. And so this is across our age group of how much do people actually interact to get there above 70% time in range that our research engaged. And you can see our newly diagnosed adolescents, children and adults, it's around the 10 minutes a day. We're asking them literally to engage, announce carbohydrates and bolus if possible. The rest of the heavy lifting the algorithm should be doing for them. So really that sort of minimal light touch engagement is what we're trying to support them engage, sort of deliver and live with type 1. Right, next slide. So we obviously know, and lots of young adults get a bad rap for not bolusing, but they are often the age group that aren't. And so how can we help them engage? Because this is a hybrid closed loop system. We are doing very exciting research into fully closed loop, but we're not there yet. The speed of insulin is a real hampering effect. It just doesn't work quickly enough and come out of the system quickly enough. So the insulin on board does a good job here, but hypoglycemia there. And so there are 3 ways currently that we enter carbohydrate via the bolus calculator. You tap on your knife and fork, and you can choose whether you can tap on and create a keypad and put in your exact 25 grams of carbs you're eating. There is a slider that you can use different, and it sort of ramps up and down the carb amount, or you can use pre-met meal sizes, which are these 4 little knives and forks that you can see at the top of the screen under meal sizes. And so there are a number of ways we've tried to sort of interact with it. People like to do things in different ways. On the next slide, we will talk about potentially a simplified meal approach, because we're trying to make life easy. And if somebody doesn't want to carbohydrate count or struggles with numeracy or literacy, communication skills, can we make it easier for people? And we've had these preset meal sizes from small, medium, large, and very large that you can set in the settings menu. You can set them between 0 and 300 grams of carbs. So there's a nice big range that people can use to then just tap on one of these meal sizes to enter carbohydrate in a sort of a more simplified meal approach, or some people use it for a constant carb approach. We may have people where I'm thinking of maybe an immigrant population where communication is a really hard tool, and so you know, the dietitians may be designed different breakfasts, but they all have similar carb contents, different lunches, different evening meals, and people sort of eat according to that. And you can program the meal sizes so people are finding it very much easier and safer to announce the carbohydrate for the bolus. This feature has always been in the app, but we haven't been promoting it probably as rigorously as we currently are promoting it. If we go to the next slide, because we didn't have the research. Everything we do, we want the research evidence. And so last year, a group published a study under Leah Bali around the SMASH study, which is a simplified meal approach. They took a group of young adults. They had a run-in period of using exact carbohydrate counting, and then they sat with a dietitian, worked out what their, you know, simplified meals were. So they were tailored to that individual's diet and eating patterns. And then they did a sort of a comparison period of time that they were using the simplified meal approach. And the results showed that it was exactly the same. There was non-inferiority, and it was just such a way of being able to get people maybe in an easier way to announce carbohydrates by simply just tapping. You didn't have to have the provision to sort of 1 gram carbohydrate. It was, you know, between 5 and 15 gram sort of accuracy level. And so certainly I, as a clinician, feel more comfortable now that I've got that research evidence to being able to announce that. And many places across the world are using that routinely now as a way of sort of utilizing and engaging, just announcing some of that carbohydrate. Let's go on to the next slide, please. So this is probably someone who you may have seen. I see some things about in the questions about bolusing and how do we to help with someone. So this is a teenager. You can see over this 2-week period, they've only sort of entered on average 28 grams of carbohydrate a day. That's certainly not the volume of carbohydrate that they're consuming. You can see, you know, the AGP shows that during the day we're okay, but we've got those sort of wings overnight. The algorithm's correcting quite hard between midnight and waking, and then working very hard between the evening and midnight. You can see 92 units of insulin, 86% is from the basal, the algorithm delivering insulin, and only 14% announced by the user. We did have some questions around connectivity, and I always look at the system setup. So you can see the system details there. Auto mode is on 93% of the time. We generally, across all our sensor use, whether it's Libra or Dexcom, would expect in real life above 90% time in closed loop, normally around the 95% time. And certainly if you see under 90% time, we would be questioning that and certainly getting hold of your Ypsomed team to do some troubleshooting with you about why that is not happening. So, you know, we haven't really seen any difference between the different sensors, although, you know, Bluetooth links and various other things may be different. But certainly I would have sort of mid-90s in my mind that I would be expecting to see. So let's look on the next slide. So this is just the same person looking at during the day, and you can see there's no bolusing at all. So CAM-OPS is not designed to be fully closed loop, but we have many people using it fully closed loop just because of where they are in their journey. So this young person, before they started the system on the pump, was sitting at about 20% time in range and is now managing to achieve you know, high 50s, 60% time in range. So that massive difference is a great improvement. They feel better. They're starting to engage with their diabetes. And certainly, you know, a positive family are happier and so forth. So we're encouraging them in that journey. We would still want them to bolus. if they possibly can. But what you can see during the day, and you saw it from the AGP, is if people have a habit, which often these young people do, they go to college and they have certain meals at certain times, the algorithm can start learning during that period of time. And you can see how the various meals, around sort of 9 o'clock and around 3 p.m. are managed fairly well by the algorithm without the meal announcement. The trouble comes at night. And what happens in this individual is they game and they have a very large carbohydrate meal. So there may be some discussions with this individual. Could we maybe use the personal glucose target? We have it at a certain level during the day, but could we potentially go lower if it's clinically appropriate between 8 p.m. and midnight? Because we know you're gaming with that adrenaline. We know it's a hard, an evening meal. If you aren't prepared to bolus or it just is something you forget, we can use the personal glucose target. We may want to think about, is there anything, if bolusing isn't possible, could we manipulate the diet? Maybe having more protein and non-carbohydrate in the evening meal, slightly smaller carbohydrate. Could we eat the protein first rather than have the carbohydrate second, so that we slow down that rise? There are other ways. But the simplified meal approach may be something that they are willing to tap on one of the knives and forks and just at least give some insulin pre-meal if that is possible. So these are all kinds of strategies you may want to utilize to support somebody who's not quite bolusing yet, getting ready, and sort of the next step into getting more bolusing in might be useful. Next slide, please. Okay, I'm going to hand back to Kleena for this case study.
Thank you, Candice. So just wanted to quickly show you one of my teenagers that I saw in clinic. He was a 14-year-old male. He had diabetes for the last 3 years. He was using MDI since diagnosis. He was kind of happy enough with that, but the parents were really quite struggling to get him motivated. There was a lot of friction between the parents and him. And we thought, giving him a closed loop system might be maybe the motivation he needed. So in clinic, we talked a lot about the different types. It was 29% time and range. Again, the parents were also really concerned at this and wanted to reduce complications later in life as much as they could. Their main concern was that he wasn't bolusing, especially in school. He was running really high levels and they worried that it was affecting his learning. He was starting to do exams in school. So their main wishes were being able to make pre-bolusing easier. So we talked about being able to do it on his phone could be better because nobody knows what he's doing on his phone. He could be on Instagram or anything because nobody can see what he's doing. So this was really important that it was less noticeable around his peers, because on MDI he had to maybe go somewhere to inject. So actually he just didn't do it. Independence. So the parents felt like they didn't want to constantly nag him. They felt it was affecting the relationship with the young boy. So they wanted to have some sort of system where they could maybe check without having to nag him. And they knew that it was constantly correcting instead of having to ask him to do it as well. They loved the idea of having the companion app and the text messages. I know there was a question about that in the chat box, which I answered. But yes, there is some great ways to monitor as well. So you can have the companion app and then you can set up these text messages so that the parents can be notified as well. And also it talks to the Gluco and mylife cloud. They were worried about hypos because he didn't have very good hypo awareness. But they liked the fact that this closed loop system would suspend once his glucose levels went below the target, and easy cannula and set changes. So that was important. So we practiced that a lot in clinic. So after a few months, you can see that his time and range went up to 75%. which was really amazing. They were all very happy. He felt well in himself. The relationship between the parents and the young man became a lot better because they weren't having to nag him all the time. And you can see that he started interacting much more with it, 9 entries a day and typing in his carbohydrates. So he was doing really well being able to manage all of this on his phone. And I'm going to hand over to Candice just to go over the last case study.
So we know we always give our young adults a bit of a bad rap. This is a case that was sent through to us around a young man who is on the autistic spectrum, and the family wanted to know what he could do better. And sorry, I tried to move the slide on my computer. If you could move the slide. And as you can see, actually, he's doing amazingly well. So this is a really good example of somebody who's getting, 92% time in time in range. There is literally no hyperglycemia. And his CV and SD are great. There's a great insulin absorption from his infusion sites. He is eating a lot of carbohydrate. Often I see these flat lines without carbohydrate. He's eating almost 300 grams of carbohydrate a day. He is in closed loop 99% of the time. He's not using booster knees off. So it's really sort of something, but obviously, people always want fine tuning and perfection. What more could we possibly do? One of my comments was enjoy, relax. You are doing well. But if we look at the next slide, you'll see that on the day-to-days, and I've just picked out a day here, this is on the day that he goes off to college, and you can see the anxiety response that is happening at 9 o'clock when he goes to school. And so, we were thinking about, from that point of view for this family, is there something we need to do? Does he need the 5 grams? You can see at about 8 o'clock, he has 5 grams of carbohydrate that he's put in at meal because he's walking to school. Does he really need that? Because we know that adrenaline rush is coming. Is that not maybe feeding into this? Is there something we can do about the personal glucose target and have it a little tighter? But it's not the end of the world that he's just dipped his head out for a little bit above 10. But if that is causing anxiety, maybe there are some tools like the personal glucose target or the use of add meal there that we might not need. You can see he has the 5 grams of carbs on his walk home at 1500 hours, but because he doesn't have that stress response of going to school, it's worked perfectly at that point. The other thing I just wanted to point out, some people often ask me, what does the slowly absorbed meal look like on glucose? This is an individual here. You can see at the evening meal, a large amount of carbohydrate is consumed, and they've decided to split it just the way they've worked out that they've give a bolus up front. Actually, they give a double bolus beginning and end, and then a slowly absorbed meal on top of that, just because that's how they've worked for it. The next slide, you'll see this is a weekend, and you can see there's no stress response in the late morning because there's no school, but the evening meal was a little bit more confused. You can see the bolus is a little bit late, so maybe that's why it's not as well managed as it was the day before. But as I said, we're really looking at fine-tuning perfection here, and giving people more strategies that they may want to utilize. But what we don't want people to do is do more work themselves. They need to use those settings, remembering I've got my personal glucose target and I've got my insulin to carb ratio, and it may be something that for the stress responses and things like that we may want to do something slightly differently, but using those 2 settings rather than ask the user to engage with the diabetes. Right, I think we've come to the end of our webinar, and we are happy. I'm just looking at the questions. If there are any other questions that have come through, I think we've answered most of the questions as we've gone along, or we've typed the answers through. But if there is anything that anybody wants to ask, or before we close this meeting, please feel free. I don't know, Clina or Helena, is there any of those questions that missed.
Yeah, there are a couple of questions that have not been answered, and I think if you are not in a rush, you can stay, and
Happy to
it will be
stay.
recorded even if the person asking isn't here. But
Sure. Do you want to ask those questions and then Clean and I can field them?
I think most of them might be answered in the question box anyways. There was one comment, just I think interesting to see the comparison. I think it was about the SMASH study. It would be amazing to see, a higher thing or a higher time and range, but I suppose it's a good place to start to see that it's non-inferior.
I think that study was designed to be non-inferior, to say this is our sort of current standard treatment, and if we do use a simplified meal approach, would we get a loss of management, which is not what we're wanting to worsen time in range. And so certainly in people who are happy carbohydrate counting, entering their carbs, fantastic. They don't need to swap to a simplified meal approach. But I think many people are struggling. They struggle with bolus timing, they struggle with entering bolusing, and so we're wanting to reduce the burden to allow people to be able to engage and find this part of what they are able to do with managing type 1. And so I think that's the real key for me from a clinical background is, can we use this as a tool to encourage people to get from their 50 or 60% time in range, to get them over, and then start aiming to get that tight time in range, that we can sort of slowly, gradually move people along and meet them where they are, rather than overface where they are and kind of lose them because we're putting too much pressure on or doing anything that they may feel that it's just too much burden.
Yeah. And it looks like another. Oh, thank you, Peter, for your smile. Then there was
a question on the follow, which has been answered, but I don't think we've touched on the follow feature in this webinar, which is important. I know we focus on it in pediatrics, in the littlies, that parents want to be engaged.
Yeah.
But I think the follow features that are available are really useful for young adults when they've, starting to get that independence. We're trying to encourage them. And certainly I've got teenagers, so I'm in that parental area where I want them to fly, but I want to make sure that they're safe and make good decisions as well. So I think that follow feature of having the companion being able to follow their children, whether they were off to university or doing something like that. And then there's the SMS features as well. So if somebody is using an Android phone, this is the difference between Android and iOS. It is just functionality from the Android and iOS. Android can send SMS. So any alert that happens on the Android phone of that child can be sent to up to 5 followers to be able to make them aware. So if there's a high glucose reading or something like that, that's sent. iOS does not have that functionality. So if the child swaps over to use an iPhone, that unfortunately is not possible. But follow is our companion functionality is possible. And so if somebody swaps over, they can have up to 10 people being companions, which is they download the app onto their phone and then they can mirror, they can see what's happening in real time, so long as both the companion and the user has Wi-Fi or connectivity, internet connectivity. At this launch of iOS, all companions have to be Android users, but we are working on that functionality. So soon as that's gone through regulatory approval, we will be able to add in, parents can also use their iOS. But at the moment, before we launched iOS, everyone was Android to Android. Now the child can move over to iOS, but the companions still have to be Android users. And as soon as it's available, we will let you know companion to companion companion iOS will also be a function. So yes, follow is important, and we will provide all of those features as we go along.
Exactly, and the fact sheet that is on the website does describe all of this functionality. So I would really recommend looking into that one. So that's very helpful. Do we have any other final questions? I think it's amazing with the engagement and that so many people are still here, even though we're after 1 o'clock. So thank you very, very much. And do we have anything final? Otherwise,
No.
I can also recommend there is another webinar coming up on the 16th of June. It's not a Nordic one, but it's a global one, and that's on very young children. So if you want to take a look at that one, I can actually put it in the chat box, the link, so you can register for that one too. So that's in there now.
Fabulous. Thank you for that. Thank you for everyone's attention. I know your time is very valuable, so really appreciate you attending.
Thank you all. Hopefully there's some tips there that can be useful.